Ahlan wa sahlan. My name is Dr. Alefi Al-Kamarichi. I'm also one of the officers. Very pleased to introduce Dr. Samir Murali, who is a board-certified physician in internal medicine, obesity medicine, and lifestyle medicine, with over 12 years of experience treating obesity with lifestyle interventions and pharmacotherapy. He completed his undergraduate degree at Rice University, medical school and internal medicine residency at UT Southwestern in Dallas, and went on to complete his master's in health services research at UCLA. From 2011 to 2021, Dr. Murali worked at Kaiser Permanente in Southern California, treating patients before and after bariatric procedures, and served as a bariatric surgery regional lead from 2016 to 2021. In 2020, he received his medical group's highest honor, the Physician Exceptional Contribution Award, for his work defining the mortality risk of obesity from COVID-19 infection. He returned to Texas in 2021 as an associate professor with UT Houston, where he has a thriving medical weight management practice in Sugar Land and Memorial City. Dr. Murali is an avid student of human behavior and is passionate about creating effective, scalable treatment platforms for treatment of obesity. Thank you very much, Dr. Murali, and welcome.
All right, I'm going to set a timer here. I'll just use my phone. Okay, I want to stay on time. So thank you, everyone. Thank you for that generous introduction. Respected elders, colleagues, friends. This is the first medical conference I've attended that feels like a family reunion. So it's a very warm welcome that I've received. Special thanks to Hatim. I don't know where he is. He's probably running around. There he is. He's been my point of contact, and everything has been very smooth because of him, and I'm sure the rest of the organizers, so I appreciate it. So there's a lot to cover here. A lot has happened in the world of obesity in the last 2 years, so I'm hoping to get through most of my slides. So it may seem a little fast. We'll see. So I have nothing to disclose, unfortunately. And I will be using off-label, I will be discussing off-label medications, or uses of off-label medications. Our objectives today are really to talk about the alternative metrics of BMI for measuring the presence of pathologic excess adiposity, talking about the current medications and what's on the future horizon, as well as discussing management strategies for obesity using these new medications as well as old ones. So I want to try to get to the cases at the end of the talk, so I might fly through some of the medications that you might be familiar with. These are the CME questions. I think you'll be answering these questions to get the CME credit, so I'm not going to go specifically through those, or we can return to those. So this will be about BMI. Each one is covering the objectives. And so here we go. So why treat obesity? Why should we treat it? I think the answer is usually pretty obvious because there's a lot of morbidity associated with obesity. We know that for sure as physicians. Nowadays, almost all of the pathologies that we treat may be linked to obesity. But with the COVID-19 pandemic, we found that obesity itself was a key predictor of death. And so in this way, there was some evidence that we were able to describe at Kaiser that actually showed obesity may in fact be have its own unique disease process. We looked at almost 7,000 patients who got COVID-19 in the Kaiser Permanente data. This was from February to May of 2020, and there were about 200 deaths in this population. This is any COVID positive group, both in the outpatient as well as the inpatient setting. And what we found was that there was a 2 to 4-fold increased risk of death for BMI greater than 40, and this is adjusting for demographics and smoking status. And what you see at the bottom of this slide is almost every comorbidity known to man, including cardiovascular disease, heart disease, CHF, renal failure. The only other condition that actually approached the similar effect size and mortality was transplant, having a previous transplant. So here you see when BMI over 40 is in the model, the rest of these comorbid conditions actually lose their significance in terms of mortality and how it contributes to in the setting of COVID-19. So this includes diabetes, COPD, the list goes on. So you can see that slide in more detail. I know it's hard to read because of the font. And this essentially shows us that there is possibly a unique pathological mechanism going on in the extreme high, in the higher BMI categories. Our theory here was that it was possibly related to angiotensin II upregulation, which you can see in visceral adiposity. And we also know that the ACE2 was the enzyme that was downregulated with COVID-19 infection. So there could have been a common pathway of pro-inflammatory hypercoagulable states. So coming to the actual question, do we really ever think about what is obesity? We know that there are BMI categories, but BMI was essentially described by this man. This is Lambert Quetelet, I believe is the way you say his name. This is a Belgian mathematician. He lived, you can see, in the 18th century. He created the BMI metric or measure as a way of describing the proportions of the average man. And so this was aimed at men, European men, and just to statistically describe the proportions of an average man. This was later picked up by actuaries in the 1920s and 1930s to estimate life insurance premiums, and then it wiggled its way into clinical medicine. And then we have this BMI categories that we're all very familiar with, and I've also included the WHO's categories for Asian individuals, because most of us, almost all of us here, have some origins in South Asia. And you can see that overweight and obesity by the WHO criteria is significantly lower than the general population, the Caucasian population, or others. And actually, this is, if you look at the Indian Ministry of Health in 2008, they actually published their own guidelines for cutoffs of obesity, which is BMI greater than 25. I know that's going to be controversial in this room, but yeah, if your BMI is greater than 25 by the Indian Ministry of Health, and actually Pakistan's Ministry of Health as well, BMI greater than 25 is characterized as obesity. So what are we really talking about when we're talking about obesity? If this is a shifting metric, does BMI actually describe disease? On the extreme ends, we can say that yes, it does, but what about these other categories, and what about these other communities? So let's look at a specific group of individuals that would be a model for pathologic obesity. This is congenital lipodystrophy. So these are people with a genetic mutation that essentially prevents them from storing fat inside fat cells. And so they have very little fat. You can see there's very little subcutaneous fat on these individuals. But the phenotype is extreme insulin resistance. They're usually diabetic by the time they're teenagers. They have fatty liver. They also have PCOS. All of these syndromes and associated conditions that you see with obesity. What's happening in these individuals is the fat is being stored not in adipocytes, not in fat cells, but actually inside their liver and in their muscle cells, right? And so this becomes a model for what pathologic obesity actually potentially is. Now, if we take this a little bit further and look at ethnic communities, this is an Australian study that was done comparing the fat distribution from Caucasian Australians to Aboriginal groups to the Chinese Australians as well as to South Asian Australians. And what you see here, I don't know if there's a pointer yet. What you see is, so this slide here, this quadrant shows total adiposity. This one shows total abdominal adiposity, and this one is visceral adiposity. The light bars are people of BMI 25. The dark gray bars are BMI of 30, okay? And so what you're seeing is the South Asian population, this is us, we have high amounts of adiposity in every single one of these categories, both in terms of total adiposity, as well as abdominal adiposity, as well as visceral adiposity when compared to Caucasian individuals, as well as to these other groups. So within the BMI category, right? So these are, if you take this bar here, this is within BMI of 25 compared to South Asian individual, to a Chinese individual, to an Aboriginal individual compared to a Caucasian. The South Asian group has the highest amount of visceral adiposity. So we have this genetic model that shows us what the dangers of visceral adiposity are, and then we're also seeing an ethnic pattern that shows how visceral adiposity itself can manifest in different populations. And this suggests that this is really the problem. It's not fat per se, how much fat is on our bodies, but actually where it is. So it's just like real estate, location, location, location is very, very important. And where your fat is located actually can put you at risk for all of these various different conditions. And it's extremely important for all of us in this room because we're extremely at high risk as per the data being from South Asia. So we know that the BMI itself, in terms of defining obesity, so if you're treating something, if you're treating fever, you have to know what you're treating, right? Without knowing what you're treating, how will you come up with a proper treatment model or proper treatment plan? So if we don't even know what we're treating in terms of defining obesity, then we're starting in the wrong place, right? So recently, this resident, Dr. Ayush Visaria, so he's an internal medicine resident, got a lot of headlines from his presentation at the endocrine meeting this year in 2023, but he actually took NHANES data, so national sampling of data from the United States, and looked at the sensitivity and specificity of BMI as a predictor of adiposity compared to DEXA scans. So DEXA scan is the gold standard for looking at body composition. And so what he found was just a 50% sensitivity and 90% specificity. The thresholds here being body fat of 25% or higher being a threshold for obesity in men, and then 35% or higher for women. And so when you looked at people in the same BMI category, BMI greater than or equal to 30, BMI only predicted adiposity or excess adiposity 36% of the time versus DEXA 74% of the time. So there's a lot of pathology that we're missing in ourselves, if you want to just get personal about it, in ourselves, as well as in the community at large, when we're thinking about this in terms of body mass as opposed to body composition. So I would like to impress upon you that body composition is much more important when we're talking about obesity and excess adiposity as opposed to total body weight. Arnold Schwarzenegger, when he won Mr. Universe, for example, or Mr. Olympia, I think his first time around, he had a BMI of 31, right? So we wouldn't call him necessarily obese at the time, correct? And the AMA has finally gotten on board with this. In June of this year, just a few months ago, they put out a statement saying that BMI does not account for differences across race and ethnicity groups, sexes, genders, and age span. And we've known this now for almost 200 years, but the AMA has just caught up. So if BMI is not the best measure, then what could we use? In the UK, they've come up with a guideline. They've added to their guideline waist circumference and height ratio. This is good for patients with a BMI of less than 35 and children. So we want the waist circumference and height to be less than 0.5. So that's an interesting measure. Impedance, this is something that is very useful in the clinic at point of care. So this is what I use in my clinic. So essentially a low-level current passes through the body, and then the amount of resistance that your body is given to that current is correlating with your body composition. So higher conductivity is lower body fat percentage because water conducts electricity much better than fat. And then higher resistance is higher body fat composition. And these are the in-body scales, the Tanita scales. You can find these scales in Bed Bath & Beyond. They have the little electrodes on the bottom. But the ones we use commercially have also handles where you can hold them so you get a better estimate of the upper body adiposity and the visceral adiposity as well. And this will give you an estimate of muscle mass as well as total body water as well as body fat. So it's a useful tool to trend the body composition as you deploy weight loss interventions. And then DEXA is the gold standard here. the limitation there is there's radiation exposure. It's expensive equipment, but it is the gold standard. There's a slightly different cutoff for women in terms of excess adiposity by the American College of Sports Medicine, 32% versus WHO 35%. 25% is the threshold for men, and there are no studies with determining ethnic variation in terms of outcomes, diabetes risk, any of that. So we don't have that data yet. Also, impedance, I would say one limitation is once the BMI gets higher, you start to see that there may not be correlation with body fat percentage. There's just not enough data for the higher BMIs. The companies are not validating their tools at the higher BMIs, which hopefully will happen soon. So let's get into therapeutics. Let me see how I'm doing on time. Okay. So this is really the exciting part of what's happening in obesity medicine. As was said in the introduction, most of my practice has been around taking care of patients before and after bariatric surgeries, but in the last 2 years, there's been an explosion of therapeutics. It would be hard to miss it as physicians, and so I'll go through that briefly. So in terms of obesity or anti-obesity interventions, here's where medications lie. There's a broad band here of 3 to 17% weight loss. So all of this data is going to be looking at weight loss. It's not particularly geared to body composition, although we would like that. Weight is still a very easy thing to measure at point of care and cheap to measure, and so that's where you see these data. So you always want to, when you read this data, you want to take it with a grain of salt, because when patients are losing a lot of weight, there's also a possibility they could be losing muscle mass. And that's something that we don't want to do, because muscle mass will cause loss of bone density. Bone density is not something that we can recover. So when we're clinicians, we don't want to just emphasize weight loss. We also want to look at the body composition as well. So this is where anti-obesity medications are. This is where bariatric surgery is. So 25 to 35%, 24 to 38% for sleeve and bypass respectively. We'll look at more in-depth data on this, but this is where the point estimates are on this slide. And so you can see that the leading edge of medications is approaching bariatric surgery, which is where a lot of the excitement is for those of us on the medical side of treating obesity. Here you can see some comparisons in terms of the various agents that are currently FDA approved. So obviously the GLP-1 agonist, semaglutide, is kind of leading the pack here. And this is where there's a lot of excitement, a lot of new therapeutics that are potentially coming out, and we'll touch on that. The workhorse for a long time has really been this phentermine-topiramate combination, and we'll look at the data there as well. But this is oral. These are generic medications that you can prescribe individually or in combination that are a tenth of the cost of what you see with the GLP-1 agents. These are the targets of treatment. So most of the targets have been central in the brain at the arcuate nucleus, where appetite and appetite regulation is. Where we're seeing more functionality is where the GLP-1 agonists can be impacting the gut itself. So for a long time, there was an emphasis on appetite, central regulation of appetite for a therapeutic target. But the GLP-1s have basically showed us that when you target both appetite and satiety, you will see a larger effect. So not just the desire for food, but the feeling of fullness. Because we've seen patients, or maybe we've experienced it ourselves, we're not really hungry, but there's really delicious food on the table. Well, I want to eat it. So this hedonic kind of drive to want to eat gets limited when you just can't eat anymore, right? You're just so full, you can't eat, you have to stop. And so that biofeedback has been shown to actually been very, very helpful at limiting the quantity of food that people consume. The only other therapy that was doing this before was bariatric surgery. And so now these therapeutics are starting to approximate and mimic the physiology of bariatric surgery, which is, again, where there's so much interest and excitement in this area. So here we'll talk, I'm just going to run through the various therapeutics and give you a kind of a rundown of what's available currently, and then we'll look at some of the future medications that are available. So phentermine has been the workhorse of the weight loss anti-obesity world. originally approved in 1959, came on the market in the 70s, and has been on the market ever since. It's a sympathomimetic amine, and it works, again, in the POMC nucleus and the arcuate nucleus, suppressing appetite, the drive for appetite, basically. Increases norepinephrine and dopamine. It is super cheap, and there are a variety of dosing availabilities from 8 milligrams 3 times a day to 37.5 milligrams. I rarely go above 15 milligrams with this medication. Most primary care doctors that I see will get the patient all the way up to 37.5 milligrams. And there's good evidence now that you don't have to get to the highest dose. Thank you very much. There's not been a lot of good studies on the efficacy of phentermine because it's been available for so long. So nobody's making money off of this, basically, right? So there's not a lot of studies that are going after the efficacy or the long-term efficacy. This has been a short-term, FDA label basically says you can use this for 3 months. There is currently a clinical trial that's going on right now called the LEAP trial that's looking at the long-term effectiveness of phentermine. So it's a 5-year study, be looking at the long-term safety and efficacy of phentermine, so that'll be very interesting. It's funded by the NIH. Dry mouth, insomnia, constipation, these are common side effects. There's always a risk that we have to tell patients about cardiovascular disease. It's relatively minimal if you're using lower doses, but when you have patients with poorly controlled hypertension or they have heart failure or arrhythmias, probably not the best agent to use. And you can use it in a pediatric population. FDA label, I think, says 16 and older. And there's going to be a pediatric talk. I'm going to be very anxious to listen to that. So orlistat would be the next. This is going in chronological order. So that was 1959. This is 1999. So there's a big gap. But there were agents, there were drugs that were released in between. People may remember fen-phen. There was also sibutramine. Other agents have come on the market and left. And this has been kind of a sore spot for patients, for physicians in my field, because every time there's a new drug and there's a lot of excitement, 2 years later, 3 years later, 5 years later, it's like, well, it causes cancer, sorry. It causes valvular disease. No, can't use that. So Belviq came and went. That was the most recent one. But orlistat has been here for a while. This is an inhibitor of gastric and pancreatic lipase. Again, it's been on the market for a while, fairly cheap, but hardly anybody uses this. In my practice, in 12 years, I've never used orlistat, and that's because of the side effects. A lot of GI problems, I'll just say. Don't wear white pants when you're taking this medicine. Because, yeah, there's a lot of gas, and that gas is not always gas. So I'll just say that. It's widely used in the VA, apparently. So I don't know if anybody here practices in the VA, but they use it a lot in the VA. Next would be the Qsymia combination. This is phentermine topiramate, Topiramate extended release, approved in 2012. It's also Schedule 4, phentermine Schedule 4 as well. When I talk about phentermine, some physicians will be like, this is in the same drug family as methamphetamine. I don't quite present it that way. I say, this is in the same drug family as attention deficit disorder medications, because it is, right? So they're very similar. Attention deficit disorder medications are prescribed online nowadays. And so because it's such a useful tool, it's important to kind of contextualize this in medications that they probably would understand, not necessarily something they would buy off the street. So the combination of phentermine and topiramate is an interesting one. Topiramate is a GABAergic agent that's used for epilepsy, and this is where we think that the mechanism of action is for suppressing appetite. So the agouti-related protein is also in the arcuate nucleus, and it increases appetite, and so this inhibits that neuron, and that's where we think the efficacy is. Wide range of dosing as well on this. You're supposed to start Qsymia slowly, so 37.5 for 2 weeks, and then you increase it, and you reevaluate after 12 weeks, and then you can increase it again. The cost is $100 to $200 compared to these GLP-1 agonists, relatively cheap. Up to 10% weight loss at 1 year, maintained at 2 years. So this is the first data where we see long-term use of phentermine. This is actually the first available evidence that we had for phentermine use long-term, and it actually has helped relax some of the regulation of using phentermine long-term. Medical boards are less likely to kind of, hunt you down if you're using phentermine long-term with patients after the release of Qsymia. You don't want to use it in patients who have glaucoma or nephrolithiasis. That's because of the topiramate component. Phentermine can cause some glaucoma as well, or worsen glaucoma as well. Dysphagia, which is bitter taste in your mouth, is an interesting side effect of topiramate, and I'll talk about that a little bit. But a lot of times it's discontinued because of some of the side effects of the topiramate, which is drowsiness, sometimes people feel a little brain fogginess, that's the cognitive dysfunction, or even the paresthesias that people might experience. Next, we have naltrexone buproprion. This is also known as Contrave. This was approved around the same time as Qsymia, 2014. Mechanism is not completely understood. The naltrexone and the buproprion were thought to be acting in the POMC neuron in the arcuate nucleus. And again, this is a medication that is used, titrated up to BID dosing, which I thought is interesting because buproprion increases norepinephrine and dopamine. And so when you look at the side effects, insomnia is one of the main side effects because you're taking it twice a day. And so 10% of the people in the study, in the randomized controlled trial, actually experienced insomnia because they're taking buproprion at night. So the efficacy, when you look at meta-analyses, is not that great, actually. And we'll look at some data on buproprion alone, which actually shows more efficacy. So I would say this agent is rarely used in my practice. It is used usually as an adjunct. I find this useful when patients have depression in addition to their obesity as well as cravings. So we know buproprion, for example, is used for smoking cessation, and so when patients have habitual cravings for other substances or foods or beverages, this can be useful. And I'm going through this a little quickly because I want to make sure that we have time for questions and discussion. But if you want me to pause on any one of these drugs, I'm happy to do that, or we can return to it. So liraglutide, this is Saxenda. This was the first GLP-1 agent that was approved for weight loss in 2014. GLP-1 agonists, if you're not aware, they act centrally in the brain, so they reduce your desire for food, and then they slow down gastric emptying so you feel more full after eating. It's a sub-Q injection, and basically the dosing goes from 0.6 to 3 milligrams daily. It is more than $1,000 for an 8% average weight loss. And so this was kind of, oh yeah, that's cool, 8% weight loss. Why don't we just do the topiramate phentermine combination, right? So these agents, when they first came out, I don't think were used very much, probably because of the cost, as well as the efficacy was not that impressive. Very common to have GI side effects, especially nausea would probably be the most common one. So generally when you're prescribing these medications, you should probably think about giving a PPI for the patient in the morning, maybe H2 blocker like famotidine in the evening, and then also some PRN, Zofran, or scopolamine patch. Whenever I write for GLP-1, that's kind of a common thing that I'll prescribe as well. Otherwise, you're going to get calls, oh, doctor, I've got nausea, what would I do? So, you don't want the calls, just prescribe the PPI and the H2 blocker, et cetera. Pancreatitis is seen with GLP-1s. I haven't had this in my practice as of yet, but I definitely have seen patients who, I've actually had colleagues who've had patients who are admitted with pancreatitis. Whether or not this is directly pancreatitis related to the drug itself or biliary related, because when patients lose a significant amount of weight, it causes biliary stasis and they can develop gallstones. But this does have action in the pancreas, so it is possible that there is a direct line of impact on pancreatitis. Recently learned a colleague was telling me that topiramate also was an agent that they've seen pancreatitis as well. So it's something to note. Medullary thyroid cancer was seen in rats. with GLP-1 agonists. And so this is something to be aware of. Medullary thyroid cancer is genetic, generally in humans. There was a study that was published in February in France that looked at Ozempic or semaglutide for diabetes, a 3-year look back, basically trying to see is there an association with thyroid cancer. And I believe the incidence was 7 in 10,000, I want to say, which is a very, very small prevalence, and it was an observational study. Wasn't able to determine if it was medullary thyroid cancer, other forms of thyroid cancer, or recurrence of thyroid cancer. So we think it's a very low probability. So pancreatitis would probably be more common than medullary thyroid cancer with these agents. Definitely don't want to use in pregnancy, so I want to make sure. Topiramate as well, I didn't mention that. So most of our agents, unfortunately, should not be used in pregnancy. And that's important to bring up when you're consulting with patients who are seeking weight loss. Many of them are female, almost 85% may be female in a weight management practice, because their fertility may improve with weight loss, and then if they're sexually active, they get pregnant, they don't know they're pregnant, and then you're exposing the unborn child to potentially dangerous agents. So topiramate can cause cleft lip, cleft palate. Phentermine is also Schedule X, but there's no birth defects necessarily with phentermine, maybe complications with pregnancy. And then GLP-1's not quite sure what happens. We don't have any data, but where the package insert says you should stop it 2 months before trying to get pregnant. And Saxenda is approved in 12 years and older. This is hydrogel, also known as, oh my gosh, I'm blanking on the name. I'm forgetting the name now, because I never use this. But basically, it is a medical device, and these are beads that get into your stomach and expand by 100-fold increase in size. So it's taking up space in your gut, and basically creating an increased sense of fullness. So these are 3 capsules BID. And the efficacy, you can see, this is why I never use this agent. Plenity is what it's called, sorry, Plenity. Because if you read the study, look at the placebo arm, 4.4% weight loss. That's a great placebo, right? Maybe even better than Contrave, right? So this is a marginal, very small marginal effect, better than placebo for a lot of GI side effect. And what you learn from this actually is that, going back to bariatric surgery, the gastric band and the vertical stapled gastroplasty that was done in the 80s, these mechanism of action was basically, the idea is restrict the stomach, make the stomach smaller, and then people will eat less, and then they'll lose weight. That has been proven wrong time and time again, right? And this is another example of barking up the wrong tree in terms of a mechanism. Satiety and reduction in appetite are more physiological mechanisms that should be leveraged, and we should press on those points using actual drug targets or surgical targets that enhance those effects. So restriction and all that kind of stuff is not the way, in my opinion. Melanotide. This is a very interesting agent. This is specifically for genetic rare forms of obesity. You can see the Bartlett-Beetle syndrome and these other rare genetic deficiencies. The prevalence of these altogether is probably maybe 4,000 to 5,000 cases in the United States. So very, very small prevalence. What is this doing? It is acting on the melanocortin-4 receptor. So this is, again, in the POMC neuron. This is the POMC neuron. The efferent side of the POMC neuron is this melanocortin receptor. And so these individuals have no satiety because they have a deficiency of melanocortin agonists. And so they don't feel full. And so this is a very useful tool to actually enhance the satiety in these individuals. Now, so basically this is the same mechanism of phentermine, but without the sympathomimetic amine effects. So phentermine is working on the afferent neuron, the setmelanotide is working on the efferent neuron. And so you're hitting this receptor, and you're not having any of the cardiovascular, the heart rate increase, the blood pressure increase. So you might ask yourself, well, why isn't this drug used for weight loss in general? It would be a great drug. And the answer is, the first side effect is hyperpigmentation. This makes you darker, okay? So you look darker when you take this medication. And the efficacy in primates, so non-human primates in the phase 1b trial, is about 13-14%. And at the same time as this was being developed, the GLP-1 agonists were also being developed, and there was a similar efficacy. So these guys, drug company thinks, well, this is making people darker, it's not as good as the GLP-1, what should we do? Well, they started marketing it, aiming it more towards the genetic forms of obesity, and it's a daily sub-Q injection rather than for the general population. It probably would be effective for the general population if you're okay with looking darker, okay? So very interesting how the drug companies think. Okay. This next one changed my life. This is why I'm back in Texas. So, yeah. This is semaglutide, also known as Wegovy. It's been around for almost 7 years as Ozempic. The data came out in January of 2021, and 2021 is when I hit my 10-year mark with Kaiser. I was vested in the pension, and this thing came out, and it came out showing 15% weight loss. So at 5 years, a sleeve gastrectomy is roughly at 18% weight loss from our Kaiser data. And so I'm looking at this and being like, wow, this drug is almost approaching bariatric surgical level efficacy. And I'm working in an HMO where they're probably not going to ever cover this. So what do? I need to go back to where the family is, where the obesity is, and where favorable business environment is. That's why I'm back in Texas. So everything is bigger in Texas. Everything's better in Texas when it comes to medical weight management. Yes, yeah. Thank you. All right. Lone Star. All right. So this is Ozempic, essentially. So this is Ozempic for weight loss. So this is a weekly subcutaneous injection. Dosing range, as you can see, also very expensive. So the efficacy is almost double what liraglutide or Saxenda is, but the cost is basically the same. There is recent data, if you've been paying attention, recent data from the SELECT trial that has come out, been published, hasn't been published, I think it was just a press release already, but a 20% reduction in major adverse cardiac events, 36% reduction in stroke on this medication at 5 years. Very impressive. This may be the path for Wegovy to be approved by Medicare, if Medicare can negotiate a better price. So also an indication that when you are treating obesity at these levels, 15%, 20% weight reduction, you're doing something to the patient's physiology to where they're no longer having these cardiovascular events. Harkening back to the data that I presented on COVID, there's something happening that the pro-inflammatory milieu of visceral adiposity is likely being treated here, and patients are having cardiovascular benefit, is what we think. Again, same side effects, GI side effects, et cetera, and is also now approved for 12 and up. The major issue with these medicines is access, right? Let's be honest about that. These drugs are priced at 3 times what the cost-effectiveness thresholds should be. And so what you'll see is, they just launched it in Germany. It'll be hopefully maybe adopted by the National Health Service. They'll probably restrict it to certain populations, maybe those with obesity and cardiovascular disease. But the race is on. Almost every pharmaceutical company worth their salt is trying to develop a competitive agent, and hopefully that'll bring the price down. I'm not sure if it will. How am I doing on time? Okay. I have an hour, right? An hour? Okay. All right, off-label therapeutics. Metformin. Is that a surprise to anybody to see metformin here? Okay, well, you're a very educated audience. So yeah, metformin is a great agent. I use it a lot, probably the most prescribed anti-obesity medication. Multiple mechanisms, but we know that metformin makes a person more sensitive to their own insulin. Super cheap, super cheap. And what is the evidence for weight loss? The evidence for weight loss is not great because, again, this is a very cheap medicine. Who's profiting off of weight loss studies done on metformin? Hardly anybody, nobody, right? And so the best evidence that we have comes from the DPP, the Diabetes Prevention Program that was done in the 90s and published in the early 2000s. There's a post hoc analysis on DPP that looked at long-term weight loss in patients who lost 5% or more on the metformin arm. So if you're not familiar with the DPP, this was a comparison from placebo to lifestyle intervention to metformin for people who had prediabetes and overweight or obesity, looking at which agent or which arm was most likely to cause significant weight loss and prevent diabetes. Actually, prevention of diabetes was the endpoint. And lifestyle, which was really impressive to everyone, lifestyle was the big winner. Better than metformin, better than placebo. And so these investigators looked 15 years down the line at those people who lost 5% or more on metformin in the first year. So that was about 35-40% of the sample. And at 15 years, those patients who were on metformin had maintained 5% weight loss or more. Not all of them, but a significant proportion. So that gives us an indication that this is a very useful medicine. It has a usefulness for weight management. We don't want to use it in renal dysfunction. Generally, I mean, there are some creatinine cutoffs. I think if you talk to most nephrologists, there are probably some in the audience. I generally don't prescribe it if the GFR is less than 40, but above 40, I will usually ask their nephrologist, hey, is it okay if I put this patient on metformin? They say, okay, then we'll put them on metformin. Generally, it is an agent that I'll use when I find insulin resistance, okay? So that's when we want to use metformin. And that's not just A1C, that's also fasting insulin. So a patient with normal renal function, fasting insulin greater than 10, that usually connotes insulin resistance. By the time their A1C is abnormal in the prediabetes range, they've already probably lost some beta cell mass, is what the data shows us. And there is, because of the risk of lactic acidosis, they generally say you don't give it to heart failure patients. There was a colleague that I met just recently, I don't know where he is, but I get a lot of LVAD patients nowadays, which is very scary. There he is. And I haven't seen this many LVAD patients in my life, and I always worry about necessarily putting them on metformin, but I get good confirmation, these patients are perfusing well on their LVAD, and so it's okay to use metformin, most likely, but ask the cardiologist first, don't take my word for it. And obviously you can use it in kids. Topiramate, we already talked about. Super cheap, but what's the data? Efficacy is greater than 5% weight loss. The odds ratio was 6. So odds ratio of 6 is really high, actually, right? The percent weight loss data is not really there because, again, nobody's doing studies on these generic agents, but we know that it has efficacy in terms of added efficacy with phentermine, and so using it as a single agent for those patients who have cardiovascular disease and can't take phentermine, using it BID or twice daily is something that can be done. Because BID dosing is also used for seizures as well as migraines at much higher doses than what's needed for weight loss. One more thing I'll say about Topiramate is the dysgeusia. The change in taste is very useful actually for patients who are really hooked on carbonated beverages. Okay, so a little pro tip here is if your patient is not, so all of the agents that we just talked about are down-regulating appetite, right? So they're helping reduce how much food a person is consuming. But a large proportion of our patients, their calories are not coming from food, they're coming from beverages. So what do? These agents you're gonna give someone phentermine who's drinking most of their calories. If you're not taking a good history, you're giving them the wrong medication, okay? So a person who's consuming tons and tons of Coke, Topiramate may be a great option because it's going to change the taste of any carbonated beverage. So I had patients who are big beer drinkers in the great state of Texas, and this also helps with that as well. And you don't need much. and they do often will reduce their consumption. Preferably, hopefully, don't pivot to flat Coke or juice or something like that. But if you educate them appropriately about the dangers of sugar-sweetened beverages, oftentimes this can be a very successful intervention. Wellbutrin or buproprion, as a single agent, efficacy is quite good. And so this was 300 to 400 milligrams once daily, 10% weight loss, way more, more than double what the Contrave data showed, right? And so Contrave is giving this buproprion BID. This is once daily extended release of 300, 400 milligrams, so potentially much more effective than the patented medication. Obviously, you want to be careful with patients who have seizure disorder and are on other medications for depression, especially the MAOIs. Hopefully nobody uses very much of that anymore. And it can also worsen glaucoma. A similar side effect profile as phentermine, but possibly to a lesser degree. So people with high blood pressure, et cetera, you want to have them monitor their blood pressure. So what's on the horizon? Tirzepatide, Manjaro, right? As my patients say, Manjaro. A lot of them will say that. Tirzepatide, this is a very, very exciting drug. So this was FDA approved for diabetes last year. And this is a GLP-1 GIP agonist, okay? So the GLP-1 and GIP are very similar. They're both incretins. They both have similar effects on the GI tract. Phenotypically, what you see with patients who are on Manjaro is they have less, for some reason, they have less nausea, less GI symptoms. I'm not exactly sure why that is, but it seems like the GIP effect is somehow reducing the satiety, or sorry, the nausea that's experienced with these agents. I've had patients who, because of shortages, they're not able to get the medication. They're on the highest dose, and then their medication comes. It's been a month since they've taken it, and they take it, and they're fine. I wouldn't recommend that. What I would say is when there are gaps in dosing like that, 2 weeks is my threshold. If the patient hasn't had their medication for 2 weeks in a GLP-1 agonist, I generally will start the titration from 0. And that's a safer way to do that. But it's very well tolerated. It's extremely expensive medication. It's more expensive than the other GLP-1s on the market, also very short supply. But almost every patient that I've had that's tried this and has had to get off of it because they were using the coupon card from the drug company and things like that and not able to get it anymore, had to switch them to another agent like Wegovy. Almost universally, the preference is for this medicine. When can I get Manjaro again? I don't know. You got to win the lottery. Same side effect profile. And so here I want to highlight the efficacy at 88 weeks. So this is the SURMOUNT-4 trial. There was a 36-week run-in where everyone, it was open label run-in, everybody was on the drug, and then they pivoted to placebo and intervention. And the 88 weeks, the patients who were on tirzepatide was 26% weight loss greater than placebo. Incredible, incredible. And so the very next slide here is to compare that efficacy with bariatric surgery, right? So this is Kaiser data. This is 65,000 patients. 65,000 patients, almost 30,000 in the sleeve arm, 30,000 in the room-wide gastric bypass arm, and about 4,000 in the band arm. 5-year outcomes, 70% retention. So one wonderful thing about working in an HMO, integrated healthcare system, is the patients are a captive audience. They can't go anywhere else for their care. And if they like it, they stay with your plan. And that's why we have this kind of data. And so what you see is the efficacy that's reported generally for bariatric surgery is this early data, right? This 18-month, 25% weight loss for sleeve, 31%, 30% for bypass. But if you take it out 5 years, there is weight regain, okay? And so what you see with sleeve is 5-year outcomes, a little less than 20%. Bypass retention is much, much better, 25%. And if you actually look at the breakdown of weight regain, which I don't have that slide, sleeve patients, 1 in 8 may regain all their weight back in 5 years. Bypass is 1 in 30. So bypass is clearly the better intervention. The reason for this actually is the GLP-1 effect. Okay, so people think sleeve is a restrictive procedure. It is not. Okay, there's one thing I want you to learn from this talk. Sleeve is not a restrictive procedure. It is a metabolic procedure. What is happening is with both of these procedures is undigested food is being transported further down the GI tract. Okay, and when undigested food goes 2 to 3 times further down the gastrointestinal tract, GLP-1 is released because the GI tract is trying to slow down emptying. If food is shooting through the GI tract, it wants to slow it down, right? Because that's where the calories are, that's where the nutrition is. The whole purpose of the GI tract is to absorb that stuff. And so the chyme, if the undigested food is racing through, GLP-1 is slowing it down. The GI tract, the L cells in the ileum, okay, thank you, are releasing GLP-1, and they're having the same effect as semaglutide and Manjaro. So these medicines are mimicking what bariatric surgery is doing. What's happening with the sleeve is, because it's narrow and long, it is the intragastric pressure is so high that when the stomach contracts, it is shooting the undigested food further down the intestinal tract. As it dilates over time, that effect diminishes. So if the patient's binge eating or overeating or such, then that GLP-1 effect declines, and that's why we see this weight regain. With the bypass, food is literally being rerouted. Undigested food is reliably being delivered distally, and so that GLP-1 effect is retained. So if your patient was on GLP-1, they lose the coverage for GLP-1 for semaglutide or liraglutide, and they're still eligible for bariatric surgery or they regain weight, bariatric surgery is a great option actually for these patients in terms of being able to be on the intervention, but without having to clamor for the medicine, yeah. And bariatric surgery is cheaper than these meds, basically, at this point. Bariatric surgery bypass in Houston is probably $14,000, $15,000. Sleeve maybe $11,000. You're paying $1,000 or more per month for these medicines, and it's potentially long-term. All right, I'm going to go much faster now. So these are GLP-1 glucagon agonists that are in the pipeline. So glucagon potentially also has an increased satiety effect, but also can increase energy expenditure and reduce hepatic fat, which is really exciting. This is retatrutide. I don't know why they named it that, but this is GLP-1, GIP, and glucagon combination. This is Eli Lilly's product, and this is looks like 24% weight loss after 48 weeks. Remember that 88-week threshold was where the big weight loss was for Manjaro, and so we'll have to see what this data looks like. There was a signal of increased risk of pancreatitis, 1 in 338, so we'll have to see what that turns out as well, because these are agonists that are working in the pancreas, basically, right? Glucagon is being released there from the alpha cells. I think it's alpha cells. Other agents, so this GLP-1 amylin product, so amylin also enhances satiety as well. The one that I want to point your attention to is the last one, HU6. This is crazy, okay? This is a mitochondrial uncoupling agent, okay? So if you know what white fat and brown fat are, white fat is regular fat, right? Your fat cell adipocyte, one droplet of lipid. Brown fat is multiple droplets of lipid and multiple mitochondria, and it is basically, babies have a lot of brown fat because brown fat is just burning fat to create heat for the baby to stay warm. Hibernating animals, same thing. And you can actually induce brown fat conversion from white fat by dunking yourself in cold water, believe it or not. So this agent is taking that same protein, sticking it in that mitochondria, and the fat cell it's literally a fat burner. Spares your lean body tissue, spares your muscle mass, you're just burning fat. So if this doesn't cause you to have rhabdo or like melt or something, this is going to be the new thing, I think. This is crazy. I mean, the science there is just incredible. So something to watch. Okay. Going to keep going here. So cases. How do we apply this knowledge? So where does fat come from? If you know what you're treating, once again, if you know what you're treating, you know If you have a diagnosis, you have a treatment plan. We're not treating weight, we're treating fat. So how is fat made? Do we know? Do we remember? This is the whole mechanism. It's super complicated. Let me dumb it down for you. That's it. Insulin and glucose, right? If you have a fat-making machine, the raw material that's going in is glucose. The switch that's turning it on is insulin. If you reduce your patient's exposure to both of those, assuming they have high insulin exposure, then you're helping them lose fat. And then everything else is peripheral to that. Their emotional eating, their sleep, all these other things. So that is what you need to do. All right. This is how I think as an obesity medicine doctor. I'm looking at 4 buckets, right? I'm looking at the patient's insulin exposure, their glucose exposure from food or beverages, their physical and emotional morbidity, and their sleep. Sleep, as you can see, is foundational to the whole thing. It's going to influence every single one of those other buckets. If you're not sleeping well, you're going to have higher insulin resistance. You're going to crave things that have glucose because you're tired. When you're tired, where does energy come from for the body? Glucose. So you're going to crave carbs. You're going to crave sweets, right? And then your physical, emotional health are going to be definitely impacted when you haven't slept, correct? So if you're not screening your patients and asking them if they're satisfied with their sleep, or they're satisfied, more importantly, with their energy level, people will say, oh, I sleep good. But what about your energy level? Oh, I'm very tired. I don't know. Well, where does your energy come from? Starbucks. No, it comes from sleep. Okay? So sleep is foundational, and then you're looking at all these buckets. So insulin exposure, checking their fasting insulin, if their A1C is normal. Glucose exposure, taking a history, seeing if they're drinking a lot of their calories or they're eating a lot of their calories. If they're eating a lot of their calories, you have lots of options. If they're drinking a lot of their calories, most of what you can do is talk to them, not treat them, okay? And then their physical and emotional morbidity. All right, this is my kind of conceptual model, I think visually. And so this is how I think when I'm seeing the patient. Do they have an aspirational goal, right? This is a faith-based community. You know, the talk about the hospital, very rousing. This is for our community. This is for people who are indigent. It inspires people, right? If you just want to look good for your wedding photos, that's not the same. It's not the same, I'm sorry. So you really have to ask your patient why they want to lose weight. That's very important. That's foundational. Next is everything else. Can they make sustainable changes? Are they slow and steady? Sleep, support from peers as well as from your clinic, their activity level, not exercise, activity level, and then meal planning. All right, I'm going to go super fast here. What I want to highlight here is under activity, exercise. Didn't talk too much about that. Everybody thinks exercise causes weight loss, right? Exercise really helps you maintain weight loss, helps you maintain muscle mass, right? And if anything, exercise will blunt weight loss because you're maintaining or building muscle. So when you say the word exercise to a lot of patients who are overweight, it scares them. They have a love-hate relationship with exercise. But activity is a much better word, okay? So non-exercise activity thermogenesis is called NEAT. If they're not exercising, ask them to track their steps. Every single phone here will track your steps, right? So a minimum of 4,000 steps is the activity level that defines sedentary versus minimal activity. So you want them to get at least 4,000 steps. And then every 1,000 steps the patient takes on average reduces their mortality by 15%. It's very, very impressive. That's a multi-country study, more than 200,000 entrants into that study. Extremely, extremely important data, and largely because we have this data now with the devices. Vegetables, very important. We want 50% of the meal to be vegetables with lunch and dinner. Patients need to plan their meals if they're going to have vegetables, right? So it's much easier to have carbs and protein, but if you're putting vegetables into your meal, it's much more labor intensive. All right, so I'm going to skip to, so this is a case, basically a patient that I started on Wellbutrin, naltrexone, and Metformin and tirzepatide. Sounds like a lot, I know. What the patient ended up staying on was Ozempic and Wellbutrin because they lost coverage for Manjaro. The net result for this patient was a 34% weight loss, but I also make a point of looking at their muscle, the percent weight loss from muscle mass. So we want less than 20% of that weight loss to come from muscle. I can't emphasize that more. Less than 20% weight loss from muscle. Why? Because if it's more than 20%, then the percent body fat reduction is blunted, or it can even go up if they're losing too much muscle, okay? So we're interested in treating body composition, not body weight. This was an interesting case because she responded, tremendously well to intervention. She was drinking a lot of sweet tea, and the Wellbutrin helped her get off of that. This will be the last thing I show, I think, because we're out of time. Yeah, we're out of time. But how do I walk a patient through meal planning? Very simple. I'm going to break it down for you. So first, you establish what time do they need to wake up. So this patient waking up at 6:30, they have to get up for work, get their kids ready for school, whatever. So now what do? I subtract a minimum of 7 hours, maximum of 7 hours, okay? Because I want the patient to get at least 6 hours of sleep. I want them to protect at least 6 hours for sleep. Okay, less than 5 hours of sleep is a significant increase in all-cause mortality. So if they say, they only budget 5 hours for sleep, I'm like, no, you're not sleeping enough. We need at least 7 hours protected time for sleep. Next, we're going to 3 hours before bedtime, that would be the end of dinner. So this patient's going to bed at 10, subtract 3 hours, that's going to be their end of dinner. So the fasting period begins at 7 p.m., right? So we're fasting from glucose, so we're limiting our insulin exposure starting at 7 p.m. Next, budget 30 minutes for dinner, okay? That's pretty reasonable. I eat much faster than that, I need to slow down. So now the 6:30 to 7 is dinner. 3 hours, subtract 3 hours, that would be an afternoon snack period. Usually I'll tell the patient to do a protein shake, one of these pre-made protein shakes for that time. This helps blunt the appetite for dinner. So we want the dinner to be a lighter meal, actually. And so this protein shake helps to blunt the appetite for dinner. We also want dinner to be a more low-carb meal, right? Because we don't want to stimulate a bunch of insulin getting into their blood at the end of the day. So what you find is people will fast, they're trying to lose weight, they're not eating hardly anything during the day, and they come home, their willpower is gone, they just go into the pantry, they're snacking, they're having a huge meal at the end of the day. It's opposite of what we want them to do, actually. Okay, so we budget, 3 hours before that would be the end of lunch. So again, a 30-minute timing for lunch. And this is where the patient can have their starch, is generally what I say. Lunch and before lunch is where we want you to have all your carbs, because that's going to give you energy for your day. And then your insulin resistance for everyone worsens as the day goes on, especially after the sun goes down. And then breakfast would be 3 hours before that. And very often, this is a weekday schedule, so this is, kind of, I say Sunday evening through Friday afternoon. And so they have some days where they're less regimented, et cetera. And generally speaking, I'll tell them to do another protein shake for their breakfast, and then also maybe some fruits or some starch for that. So breakfast and lunchtime are where the fruits or starches may be coming in, and we're asking them to kind of be low carb after that. So you're not telling them never consume a carb ever again. You're trying to be very reasonable. And what this is a 10-hour eating window, 14-hour fasting window. So that 14-hour period, if they're insulin resistant and you're giving them metformin is helping with the fasting end so they can get in ketosis. Ketosis is the only mechanism we have to burn fat. And during the eating window, these agents that are limiting their appetite are helping them be more adherent to the schedule. The phentermine or the GLP-1 or what have you, it'll help them be more consistent with limiting their portion sizes or the frequency of eating, and that's how all the medications and the behavior actually work together and how you can limit the muscle mass losses, again, because you're supplementing protein, liquid protein, because with these agents, they'll consume less food protein, and the liquid protein is important because then you can keep their protein intake relatively normal and they won't lose a lot of muscle. So I will conclude, there's a bunch here, with why do I treat obesity? And that is because, well, you can see that was me. That was me in my Rice graduation. I don't know, I messed up the animation. But yeah, I've struggled with obesity pretty much since I moved to the United States. We were abroad in Dubai and Holland when I was a kid. I was born in Oklahoma. When we came back to the United States, it just blew up. And so This is very personal for me. This is why I've been doing this for 12 years as opposed to GI or radiology or whatever my parents wanted me to do. And so I'm very, very blessed and fortunate to be doing this work. I think it's very important work. I encourage you to try to do this in your practices as well. And thank you. Thank you for the warm welcome. I appreciate it. Thank you so much.
Dr. Murali, thank you so much for that wonderful, wonderful, comprehensive talk on obesity. We do have time for just a couple of questions, if that's okay. We have one right here.
Absolutely.
Hey, Dr. Murali, thank you very much. Very nice talk.
Oh, there we go. Hi.
Short.
That's okay. No worries.
From a cardiac standpoint,
Yeah.
I know it's a broad question, but I see a lot of cardiac patients. I'm a cardiologist.
Sure.
They ask me, what can I do to lose weight?
Uh-huh.
If you had to maybe name off a couple of agents that would be safe for patients with CAD, CHF, arrhythmias,
Yeah.
is there anything that you would consider maybe starting off with or that I could suggest to them?
Yeah, so just like with cancer or cardiovascular disease, there are types of obesity, right? There are types of obesity that are driven more by psychological drivers, by functional drivers, patients with a lot of pain, immobile. There are environmental drivers, social determinants of health. I didn't get to talk about too much of those, biological drivers. So it's important to kind of have an understanding as to what's driving weight gain, and this is where the history is important. But quickly, what I would say is what is missed time and time again in almost all my patients is sleep apnea. When we're not treating sleep, every single one of those other buckets is being affected. And so if you have a patient who has a BMI greater than 35 and they're hypertensive and they're male, they should be getting a sleep study, in my opinion, right? But there's so many who are not getting a sleep study. Patients who are saying they're waking up at night because they're going to the bathroom. They're not going to the bathroom, most likely. They're waking up because they have apnea. If you wake your dog up in the middle of the night, it's going to want to go out to pee. Anybody would have to do that. It means the depth of sleep is not getting there. So I would say that's important. In terms of other agents, if you can get them on a GLP-1 if they have diabetes, Ozempic is usually widely covered. There is a way to get patients on Ozempic, in my opinion, microdosing. They can buy the large dose pen, the 8 milligram pen, and actually count clicks. Every 9 clicks on the 8 milligram pen is 0.25 milligrams. So if you get them to 0.5 milligrams on that, it's roughly $230 per month. So they're paying $930 every 4 months. A lot of patients can swing that. Otherwise, you can do Topiramate BID. You should always look for insulin resistance and never, ever miss an opportunity to give the patient metformin if there's insulin resistance.
Another question. Please introduce yourself.
Okay, hi, I'm Zara. I'm a
Hi, Zara.
dietitian.
Yes.
So my question, great talk, thank you.
Yeah.
My question is about exercise
Mhm.
and in terms of preservation of that muscle mass.
Mhm.
What are your recommendations after starting on a weight loss regime?
Yeah. So behavior change is about feeling successful. If you don't feel successful, you won't continue doing the behavior. You have to feel success. And so rather than giving patients these, what the guidelines say, 150 minutes, 5 days a week or something like that, you ask them, hey, what do you like to do? How do you like to move? What is it that you're doing now? Can you do a little bit more than that? And usually I'll include what time on this schedule, when we make this schedule, when will you do it? And put it in the schedule. Okay, well, you have time after you come home from work? Great. When is that? 5:30 to 6? Okay, perfect. We put it in the schedule. Protect this time for activity. I don't care if you do 2 minutes, 3 minutes, 5 minutes. Go walk. Walking is the best. Everybody can do it, hopefully. If they can't do it, then you need to send them to a rehab center or something like that, where maybe they can do aqua aerobics. But I think we get a little too all or nothing with these recommendations. Our patients have that cognitive distortion as well. They think in all or nothing terms. They see you, they'll go, all full bore, go extreme, and then they flame out, and then you don't see them. And then by the time you see them again, and 8 months later, they've already gained 30 pounds. So we want incremental change. We want them to feel successful as they make these changes, whatever it is. Help them start small if they're not exercising at all, tracking the steps, right? You're tracking the steps, you're doing 3,000 steps, great. Maybe next week, can we do 500, average 500 steps more, 250 steps more? You give them small goals, they'll feel successful, they'll automatically do more. You don't have to tell them, increase it to this, increase it to that. Yes. Okay.
Recent reports about Ozempic being associated with suicidal risk. Is that something which is panning out, and is that going to be a concern going forward, because it's a wonder drug that is really taking off, and now there's some association with suicide?
Yeah, so I think it's actually the opposite. What you're seeing is, the action at the arcuate nucleus seems to be helping with habitual behaviors in general. So patients are gambling less, they are drinking less alcohol, there's actually improvements in anxiety. What you may be seeing is people who have a very strong hedonic drive, that food is replacing something. Many patients who have very significant trauma, abuse, these types of things, and as a child, for example, as a child, you don't have access to alcohol and drugs. They will consume food, sugar-sweetened beverages. That becomes the drug of choice from a young age. So now, with these medicines, their desire for that declines significantly. So it's like if someone with very significant bipolar is self-medicating with alcohol, and you take them away from alcohol completely and you're not treating their bipolar disorder, what's going to happen? You've taken their medication away. And so that's why it's important to have a very comprehensive approach. I didn't go through my assessment, but a PHQ-9, which is a depression screen, GAD-7, looking at their anxiety, also looking at disordered eating behaviors, asking about who they're living with, the history of trauma. All of these things, my intake form takes about 15 minutes for people to fill out, because the psychiatric portion is very much investigated in that with validated measures.
Another question on the women's.
Yeah, my name is Alifia Fakhri. I work as a hospitalist.
Yes.
My question twofold. When you start the Ozempic and the Manjaro, how long do you take it? Is it like indefinite? And then the side effects regarding pancreatitis, which I get to see a lot in the hospital, does it start immediately, or it can just start spontaneously anytime you take it?
Yeah, very good question. So, in terms of how long the patient is on the medication, generally I tell them they're in the driver's seat in terms of that. Whenever they feel, essentially, if you start a patient on an antihypertensive agent and you bring them back in clinic and their blood pressure looks great, you don't say, "Oh, your blood pressure, you're healed. We don't need this anymore. Well, let's stop everything." No, when the A1C is controlled, you don't stop metformin, you don't stop anything. So the same idea here, right? When the patient has lost weight, that doesn't mean the cessation of therapy. Okay, some patients will need more longer term therapy because their behaviors, they're not able to overcome. For example, these patients with really severe psychiatric traumas, et cetera. Food has become a part of their lives in a very intimate way. They have an intimate relationship with food, and they may need long-term treatment. But there may be other people who they had an episode in their life, they got divorced, something happened, and they needed some boost to recommit to themselves. So it's only when the patient's behaviors overcome what the medication is doing, that's when you would titrate it down, not stop it. And the patient will tell you. The patient will come and tell you, "You know what, doc, I'm ready to get off this medicine." And you say, "Okay, let's reduce it and see what happens," right? In terms of pancreatitis, I think the hospitalists and inpatient providers are going to see more of this because of selection bias. I don't see any at all, actually, in my practice. I haven't seen any, so it's probably due to happen. But my perspective is the risk is relatively low. Given the benefits here that you're seeing, the effect sizes that you're seeing, I think the risk-benefit ratio definitely, in my opinion, favors treatment.
Dr. Murali, we have one last question for you over here, and then we'll break.
Great.
Hello, I'm Moise Menakib, orthopedic surgeon.
Sure.
So, great talk. Fortunately, we have a lot of brown fat in this room, so I think we're going to be okay.
Yeah.
But question for you, again, leading off the last question, a rebound effect of these medications. Again, if you do have a patient who's got pancreatitis, something along those lines, and you do have to stop it or titrate off of it, whatever the case is, do you see a lot of rebound effect with a lot of these therapies? What percentage do you expect from that standpoint?
Yeah, so a patient who's needed treatment and responded well to treatment probably should be on something. Again, I come back to the hypertensive patient. If they, let's say you're on an ACE or an ARB and they're having lots of cough or something like that, you stop it. That doesn't mean they usually, let's just, blood pressure, yeah, we don't have to treat that. So there are other agents, and so one of the other cases that I have in my deck is a patient with pulmonary hypertension, didn't have any coverage for these agents, and we got her on the transplant list, 14% weight loss with a combination of Zoloft, Topiramate, and Metformin. So again, if you understand what is driving the weight gain in the patient, you will be able to select an appropriate treatment. So this is not about weight loss. First, it's about body composition change, but secondly, it's about us taking a good history and understanding what is driving the weight gain in the patient and then providing the appropriate combination of treatment.
Dr. Murali, thank you again very, very much. A wonderful, wonderful talk. You may be wondering why we asked you here to speak for us. And the pretense of this is that this conference is based on His Holiness Sayyidina Mufaddal Saifuddin, who is our religious and spiritual leader. It's on his initiatives that we base this conference. And one of those initiatives is healthier lifestyle, battling and tackling obesity. Like yourself, I deal with obesity. I'm not your poster child bariatric surgeon, but I think I do a good job, and in Texas it's okay. But thank you very much, because your talk helps us in that battle and helps us fulfill His Holiness's wishes within our community. And first of all, we will pray for you, and thank you very much for that. And we would like to invite you down here for this gift. This gift has a Quranic verse called وَإِذَا مَرِضْتُ فَهُوَ يَشْفِينِ. And that's a Quranic verse that says, when I am sick or ill, it is He who cures me. And that's our belief in everything, and that's what we feel, and our doctors work with that philosophy that it is He who cures, but we become the tools of that cure. And in that, you are part of that today.